Hi, everyone, and welcome to the University of Toronto Joint Centre for Bioethics Seminar Series. I'm Angel Petro-Panagos, and I'll be the moderator for today's session. Our speakers today are Haroon Yousuf, Andrea Frolic, William Harper, and Simon Oczkowski, and the seminar is entitled Triage-Ed, Lessons Learned from Educating Clinicians on Pandemic Critical Care Triage Protocols. Now, before I begin and introduce today's speakers, I'd like to let you know that the seminar is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Centre for Bioethics website. And the format for our seminar today is a presentation by our speakers, followed by a facilitated discussion period. We wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, the Mississauga, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. Now it is my pleasure to introduce our speakers. Haroon Yousuf is a general internist and clinical ethics consultant at Hamilton Health Sciences. He is currently the Deputy Program Director for McMaster's Internal Medicine Residency Program. Andrea Frolic is the Director of the Program for Ethics and Care Ecologies and was an ethics consultant to the Ontario Critical Care Command Center on the development of critical care triage processes. William Harper is an associate professor of endocrinology, division director in the Department of Medicine at McMaster University. And Simon Oczkowski is a critical care physician at Hamilton Health Sciences and contributed to the planning for the emergency standard of care at Hamilton Health Sciences. Everyone, welcome. It's our pleasure to have you here today, and I'll turn it over to you.
Thanks for the intro, Angel. As Angel said, our talk is entitled Triage-Ed, Lessons Learned from Educating Clinicians on Pandemic Triage Protocols. So I'll just move into our objectives. So we're hoping to review educational strategies for triage education, what's been done in the past, describe the implementation of our educational strategy here at HHS, which included virtual town halls, rounds, just-in-time education and simulation, and then discuss some of the educational and organizational lessons learned. So in terms of the review of literature, I apologize that I have not included a reference here, but when you're looking through how to educate clinicians on triage, it's actually very scant literature. Most of it is based on ATLS. There's a lot of literature on triage protocols, but on how to educate clinicians, not as much. And nearly all the training programs are ATLS based for physicians or ATCN based for nurses. And there's very limited literature on how to educate an entire interdisciplinary healthcare system for triage within the ER. And outside of the ER, it's almost non-existent. So I'll pass it over to Simon now, who's going to talk about our institutional context and then move into some of the first step of our educational strategy for triage pandemic, for educating for the Ontario emergency standards of care.
Great, thanks, Haroon. So I'm going to forego the sort of typical, starting in 2019, there was a global pandemic. I think we all are very aware of that. And so what we're going to skip to instead is sort of the institutional context in which these educational activities were undertaken. So Hamilton Health Sciences, just down the road from Toronto, it's a large academic healthcare center, includes multiple geographically disparate hospitals spread over the region, and provides care from pre-birth antenatal care, pediatric to end-of-life care and palliative care. And as a large organization, it included 15,000 staff, including physicians, learners, and allied health, as well as administrators, all of whom would potentially be involved in pandemic triage. So this is a monumental undertaking in terms of what had to be brought to the fore with regard to triage. Next slide. And the context of this, and I imagine there have been many JCB seminars on the topic, but I'm just going to provide a brief overview of triage itself. So the triage process in Ontario evolved starting in March 2020 all the way through to March of 2021, under the direction of the OCCCC or OC5. And in brief, the triage approach taken was to use short-term mortality risk, or STMR, you'll hear it referred to throughout this presentation, in order to prioritize patients based upon their survival. And roughly the cutoffs used were 80%, 50% 1-year survival, and 30% survival at levels 1, 2, and 3 of triage. And in order to calculate these, it used validated disease-specific scores. So for instance, there are well-validated scores in the setting of trauma, in the setting of sepsis, in the setting of intracranial hemorrhage that predict mortality at 1 year. And these scores were all collated into essentially an STMR calculator that brought them all together for clinicians to be able to predict the 1-year mortality risk of the patients under their care in the ER, on the ward, or in the intensive care unit. And these STMR calculations and the triage process will be completed by a primary clinician and a secondary clinician. And there was, throughout this year, there was evolving approaches to the role of, for instance, triage teams. Would they be covering hospitals, covering across the city, virtual, how this would be done in terms of local oversight, how it would be reported, how it would be recorded and documented. And so we're not going to go into too much detail about those processes, because they did in fact change throughout the year, from the very beginning of March 2020 at the beginning of the pandemic towards the alpha and delta waves in the spring of 2021. Next slide. And roughly how triage was intended to work was the idea, and this slide has very, very small text. You don't actually have to read it, but the idea is that percent of ICU capacity is the Y, or vertical axis, and time is the horizontal axis. And that purple line represents the amount of capacity in ICU that's being used by patients, with the idea that as the pandemic would ramp up, the ICUs would go into surge, that is over 100% capacity. And at a certain point, when all available resources had been maxed out, it was recognized that there was not going to be sufficient resources to provide an adequate standard of care. We'd have to invoke an emergency standard of care or a triage protocol to identify which patients would be prioritized for ICU care. And so you would first reach level 1 triage, where patients with the highest 1-year mortality risk would be excluded. As we continued to run out of resources, you'd move to level 2 and eventually level 3, and then the process would happen in reverse as the ICUs cleared out. With the idea being that patients who were who had a high mortality risk would be excluded from the ICU first. The idea trying to admit patients to ICU with the greatest chance of survival at 1 year. Next slide. So this was, this is a very different process of triage. As Haroon said, there's very limited evidence on how to educate clinicians on triage, and this is triage different than that is what is normally done and taught anyway in terms of ACLS, where one aims to prioritize patients based upon acuity and need. We actually usually, in a clinical context, triage people who need care to get it sooner. This sort of triage was doing triage in reverse, deprioritizing the sickest patients in many ways. And so we identified many educational needs. So first was just how do you calculate these clinical scores, the nuts and bolts of the STMR calculations. Although these are validated tools and they were often familiar to clinicians who specialized in an area, we recognized that triage was going to be carried out by emergency room physicians, internal medicine physicians, surgeons, whoever happened to be on the ground taking care of a patient at any given time. And so they actually needed education in terms of how to calculate the short-term mortality risk. There's also a need for education in terms of the triage process itself, which, as I said, evolved to a great extent over that 1-year course in terms of how do you triage, and when do you start doing it, and when do you stop doing it, and how do you document, and how do you communicate when you've got to triage, and you triage somebody and you use a form. Who does that form go to? How does that get reported? Who provides oversight? What about appeals decisions? These sorts of things. So there's a huge amount of triage process that was evolving and had clinicians needed to be familiar with. Thirdly, communication of triage with patients and families. So this was anticipated to be an incredibly distressing and injurious sort of conversation for all parties involved. And so there's a recognized need for clinicians to learn how to communicate these sorts of decisions with patients and families and support that kind of communication. And lastly, also interfacing triage with other care processes. So for instance, what about goals of care discussions that we should be having anyway? When do you move from that to triage? How does triage impact surgical practice? How does triage impact ER flow? There's all kinds of other education and how to integrate triage within other workflows across the organization. So tremendous educational needs in a variety of realms. We also recognize this is not only an educational need, but a high risk scenario. So there's a risk of implicit and explicit bias in triage decisions that clinicians may be undertaking. I'm sure you've had a number of JCB seminars on topics related to this. There are risks around if we don't educate people and they calculate the STMR incorrectly, they might over and under triage simply due to technical problems. And it was recognized that because these are new calculations, a new process, there was a high risk of emotional and cognitive overwhelm. And so even without bias playing a role, just from a technical standpoint, it was risky and prone to error. It's also important to recognize that this had to be a rapid process. So, these triage decisions would need to be made quickly across the organization. It would probably be ramped up and implemented in a very time-sensitive sort of approach and required a whole system to support it. It was also risky because, as I mentioned, this was clearly going to be a very traumatic experience for patients and families visiting our hospitals, seeking care, and risks not just from the process itself, but also if the communication is carried out, increased and added trauma. And then lastly, the high risk of clinician distress at denying standard of care treatments to patients who might otherwise receive it now, have a reasonable chance of survival. Along with the risks of having to continue care for those with a poor critical care prognosis. We already know that distresses clinicians. Next slide. So we had a multi-pronged educational strategy that I don't think any of the four of us would say was guided by some overwhelming, implementation strategy as we're presenting it here. These were different prongs of education that sort of evolved alongside one another, fed into one another, were picked up and carried by various members of our organization. So these include, and we'll talk about these, the virtual town halls and grand rounds, socializing the concept and need for triage, creating shared resources using what we call the Mac drop drive. And then we'll spend a lot of our time talking about simulation and how we worked through simulations. So in terms of virtual town halls and grand rounds, these are probably the most conventional way to provide education to clinicians, be it nurses, physicians. We all do in-services, we all do grand rounds, we all do seminars. And so actually our first virtual town hall and triage, I think where it was formally about the triage process, was in April of 2020 that I could find. Earlier talks about pandemic that we had in our organization did talk about triage as a concept, but the first sort of nuts and bolts and here's how it might look was in April. And we conducted multiple sessions in really the highest yield areas of the organization where this is most likely to have an impact. So internal medicine, surgery, ER, critical care, and then with our postgraduate trainees who float across the hospital. And these town halls and grand rounds would sort of wax and wane over the course of the year as ICUs filled up and decanted, as Dr. Harper will show in a little bit. So we actually ended up having these town halls in these highly prioritized areas multiple times. And in this sort of setting, we recognize that there's a very limited utility of these kinds of educational sessions. Really what you can get through is, why are we doing triage? A brief overview of what the criteria would look like in the STMR calculations, sort of the basics of the policy and process, and trying to enhance some capacity for clinician discussions regarding end-of-life care. But it was really more of an informational provision. There was not really any opportunity to practice. And I suspect if this was our only educational approach, we would have not have been particularly successful. So we used other strategies as well. Next slide. One of the things we realized was that in the chaos, and I think all of us remember transitioning to Zoom, where we are right now, everything in most healthcare organizations, most workplaces were undergoing radical transformation in response to the pandemic. And people were not able to attend meetings. People were changing meetings. Every policy in the hospital was being changed seemingly. And we recognized that, when triage was going to be implemented, there was a need for just-in-time education because people are not going to be able to prep in advance. There will be a fairly limited opportunity for that. So we thought it was important to decentralize and provide educational activities with current policies, protocols, tools, and educational materials. And we did this using something called MacDrop. Everything at McMaster has Mac at the front. It's kind of like McDonald's, it's McDonald's. But this is a secure university-based Dropbox-like archive. And it's secure from a perspective that you can even use it for research and things. And it's password protected. And we kept all of our most recent up-to-date policies, protocols, tools in here as and it evolved from being initially a triage team resource, a place where those of us working on these policies kind of did our document editing, and eventually evolved into a broader educational resource used across not only the Hamilton region, but it was shared quite widely across Ontario as a resource. So very widely used. Next slide. And in the MacDrop, we included things like a generic triage slide set for use, one-pager standard operating protocols, tip sheets for clinicians, policy and documentation templates for other organizations that are wanting to pick up and use the approach that we had developed, video demonstrations of clinicians, and Dr. Harper and I did a few of these in this very office where I am right now. As well as resources for discussing triage with patients and families. So we included things like scripting, FAQs, handouts, leaflets, so that if this were to actually be implemented, clinicians could go to the MacDrop, find all of the best resources, the most up-to-date resources available. Next slide. And there were some benefits and challenges to this approach. So the idea of virtual content is really appealing because it allows real-time dissemination of these materials. So as they changed, as our policies and protocols changed, we could update the Mac drive. And it allowed programs to go take those materials, bring them back, modify, edit, adapt them as needed for their own internal education. Sort of like this domino diagram I have here. We had the MacDrop, and then people could take it and work with those materials elsewhere. So this decentralization of education using centralized resources. One of the downsides was this was vulnerable, and I think Andrea was at a meeting once where the MacDrop went down and no one could get into it, and people at this point, people across the provinces were trying to use it, and it was just an internal McMaster server error, but it just made the whole process very vulnerable. It was also very challenging for us to organize and curate a large volume of material so that someone entering the Mac Drive environment could orient themselves, find the materials they need. Having it work as a standalone resource was quite time consuming. And then just-in-time education in and of itself, although it solved some problems, it was risky because, again, these are high-stakes decisions prone to bias and error, and having someone flip through some documents is not quite the same thing as actually experiencing or practicing. Next slide. So that brought us to why we decided to simulate, and I'll hand it over to Haroon at this point.
Perfect. Yeah, so as Simon discussed, our two previous educational strategies, they have both their benefits and their drawbacks. We found the same with simulation. So we realized that it's something that is necessary, and the pros were that it would push staff to actively engage with the material because it's hard to get bi-directional feedback with virtual town halls and just-in-time education. So we need to know if staff is really engaging and what they're thinking. It would help us assess the skills of various practitioners, really get a sense of where people are in our organization and what we need to provide as educators to help them. In addition, it could identify potential pitfalls in the policy and implementation. So until you've simulated out an entire process, there may be small little nooks and crannies that you only identify through simulation. And of course, it facilitates emotional engagement and readiness. So it really helps you embody this challenging experience and see how you can prepare for it. The cons, and as listed there, quite a few. First is it creates moral distress. So we had a lot of, and we'll talk about it afterwards more in depth, but it was a very challenging simulation to perform, both for facilitators and participants. We had a workforce that's already stretched and stressed, so this is adding on to that. In addition, in the pandemic setting, we're unable to do this safely in person. So can this be done virtually? And if it's done virtually, can it have high fidelity? By means that we mean, is it in a virtual setting, can it recreate what would happen in real life? In addition, if we are doing it virtually, can we provide the necessary moral distress debriefing and facilitation that that's necessary? And then finally, it's an inefficient education strategy. So you can only run a few SIMs for a small number of clinicians. It definitely can't get involved, thousands of individuals involved. And for that reason, it's a bit inefficient. But we still decided that it's important to go ahead because it's such a high stakes. This is such a high stakes decision for everyone involved. And I'll let Will Harper explain why it's such a high stakes decision and why we went and decided to go ahead with simulation.
Thanks, Haroon. So yeah, I mean, obviously being involved through this process, particularly afterwards, I think we had a lot of people questioning, why did we put me through these simulations, and why were we even entertaining this when it was probably something we weren't going to need? And it's interesting. I mean, you can see through the various pandemic, this is up to date as of yesterday, we had the initial wave and things sort of settled down in the summer of 2020, and our ICU capacity here went to near zero. But then shortly after Christmas, we had our sort of second wave, and then we were really hit hard in the third wave in the spring, which was really probably, this was the wave marked out by the Alpha variant. And part of the problem was we never really had this lowering of the ICU capacity. We sort of went down a little bit, but then we started rising quite a bit again. And it was at this point that we were really sort of doing a lot of the sims and getting ready, because we were anticipating that we were going to have to activate the emergency standard of care, the ESOC, and begin doing triage. And we were trying madly to train people to do this. And every time, when we talked about that capacity that Simon mentioned, or Dr. Oczkowski mentioned about, when we were going to enact it, we were always talking about when we get to 600 patients in the ICU, 700 or so forth. And you can see we sort of blew past those numbers. And the focus instead was just towards increasing capacity, increasing more ICU beds, being willing to transport people by helicopter, by bus, by ambulance, what have you. And I think what came out of there was this myth that, Ontario never really needed to triage. And so I think a lot of people will sort of say this was a very negative thing to have put people through. But I don't know that we know that. And I don't know that the decisions we made not to triage were always the best decisions. And in fact, some form of triage made it happen maybe informally. Next slide. I remember when we got the instructions to not begin triage, one of the questions that came out is that STMR type triaging wouldn't actually increase capacity. And we just sort of did an informal audit of our ICUs at the Hamilton Health Sciences there. And this isn't a large number of patients, but you can see here that there were people that were going to be identified. Interestingly, COVID patients were less likely to have higher mortality than other patients that have been there for non-COVID. But there were fair number of people, 40% that you wouldn't triage at all, 20% you wouldn't triage except for levels 1 and 2. And then when you also look at people that are going to be in the ICU for a prolonged period of time, something that is ascertained through something called the Provent scoring, it was quite clear here that there was a fair number of people that were there for more than 14 days, and depending on the level of triage, might be eliminated from not necessarily entering the ICU, but they had been in the ICU for long enough. So I don't think it's actually true that STMR and ESOC level triaging wouldn't have identified patients that could have been removed off ventilation or denied ventilation and an ICU admission, hence increasing capacity for others. I think we would have found that that would have increased capacity, allowing us to potentially still proceed with care for other patients and maybe not shut down necessary emergent services as we've done during that wave and indeed during the current wave. Next slide. So I think we have to understand that not activating ESOC triage has consequences. Triage happens, it's informal, it's haphazard, inconsistent, and it's done by the frontline clinicians. We also know that we're delaying elective care, and elective care isn't non-urgent. I mean, it's just not emergent, but it's cancer surgery, it's chemotherapy, cardiac revascularization procedures, sometimes even intracranial emergencies. One of those happened in the spring as well. The other aspect that is important to understand is the surge capacity leads to substandard care. We're having redeployment of staff that don't normally work in an ICU. We're expanding ICU services into areas which are not normally ICU, like post-operative care recovery units, heart investigation units. We're also having patients that are normally cared for in an ICU setting being cared for on a ward. High flow oxygen patients are normally only cared for on a ICU setting. I personally have taken care of many high flow oxygen patients, and it's kind of risky. But the other aspect that's important, and one of the reasons why I think there was a lot of pushback against ESOC, is this concept that there was a concern that there was an implicit bias or a risk of ESOC and STMR assessments being more biased towards people and creating a risk that, poor people or racialized people might not be triaged properly. But in actual fact, you look at the data that came out of New York, the opposite happened in a situation where, we can go to the next slide, where they did not have any kind of standardized way of doing it. You can see here that there was, not surprisingly, as people went up in age, increased mortality, less likely to be discharged, but there were differences in racialized groups, most of which was not statistically significant except for in Hispanics, but very concerning in terms of poverty status. There was a much higher rate in people of higher amounts of poverty of being potentially misallocated in terms of, and we don't know why that happens. We don't know why somebody might determine ICU level care will be done in the normal ICU by normal critical care patients, whereas who are we going to push out to the extra ICU beds being managed by people that don't normally do ICU care? And are we making those decisions systematically, or are we making those decisions subject to bias? And it looks like the data coming out of New York in their first wave was suggestive of a bias. So next slide. That's back to you, I think, Haroon. I think this is back to you, Haroon.
Oh yeah, sorry, I started talking without unmuting myself. All right. Yeah, so then we moved into, because recognizing the importance of this, we had to create a team to run the simulations. And because of the complexity of this, we had 3 divisions within that team. So there was, we had to, because this was all being done virtually, we had to have a technical team. And so that technical team was our medical students who really stepped up their game, and they had already created a virtual simulation platform, and we adapted that to our needs. They also provided technical support while we were doing our simulations, and I'll talk a little bit about the format of our simulation, but that included creating Zoom links, breakout rooms, etc. And they also provided standardized patients to role play the parts of a patient or a family member who would be having conversations with clinicians. We then had the clinical team, which were frontline clinicians, physicians, nurses, and social workers who helped create the cases. And we had about 6 cases, ER case, medicine, nephro, hem-onc, and surgery cases. And they would also, these individuals would also provide debriefing and feedback after the simulation was run. And then finally, there was an administrative part of the team, and they socialized the idea of simulation. They recruited participants and audience members for the simulation, and they provided some of the education on the administrative protocol. So once the triage decision happens, who are you going to be informing? What are the logistics? And so in terms of our simulation, we ran about 4 simulations. So those were the larger groups. And within each simulation run, we had about 5 to 6 different breakout rooms with individual simulations happening in each of those. So about 20 simulations were done in total. We did 2 at Hamilton Health Sciences, and then St. Joseph's reached out to us because they felt this was a need. St. Joseph's Healthcare in Hamilton reached out to us because they felt there was a need for their clinicians. And we arranged 2 at St. Joseph's as well. So in total, we had about, I put 16, we had 20 physicians, nurses, social work, spiritual care, and administrative participants. So in each room, you'd have 1 physician, 1 social worker, who play the role of the clinical social worker on the floor, the bedside RN, and then you'd have an administrative participant. And then they would go through the STMR, have a discussion with the standardized patients, and then move from there. We had about 220 observers, 25 of which were physicians, and 170 were allied health and frontline clinicians, and about 20 were administrative staff. Okay, and like I said, we had participation from our internal medicine division, ER, nephrology, respirology, ICU, hem-onc, and surgery divisions. So in terms of the simulation format, it was done on Zoom. We did the large group session will start with a 20-minute intro and video. And we found even though we did the just-in-time education, we found a lot of people when they'd show up were not that familiar with the triage protocols as they thought they were. And so we did just-in-time education again. So 20 minutes of an intro and video. We then break out into those 4 to 5 breakout rooms. Again, 1 physician, nurse, social work, or spiritual care, and an admin participant. And we also have an ICU physician coming in as well, playing the role of the ICU physician, because there was a MRP physician doing the STMR and an ICU physician. Each room had this individual tech person, SP, and the aim was to complete the sim in about 30 to 40 minutes. We'd have 15 minutes to debrief within the breakout room about how this individual sim went, and then 15 minutes to debrief in the large group session, ask questions, clarifications. Of course, this took much longer. The aim was 1.5, but I think most of the sims lasted about 2 hours, 2 hours, 10 minutes. Here are some of the screenshots of our simulation. So, we were able to create a fairly, I'd say fairly high fidelity virtual format where we recreated the EMR. So, clinicians could actually look up their patient's past medical history. They could look up any blood tests. They can't order tests in this one, but because that was not the aim of this simulation, but they could look up any test they want, any available imaging, x-rays. They would then have the opportunity to complete the STMR in real time themselves on virtually, and then also the ICU physician who would be calling in could complete it as well. And finally, then it would move into, based on the decision, move into a discussion about what the score found and whether the individual will be deprioritized for ICU. So in terms of the lessons that we learned about simulation, one of the challenging things, is that there needs to be a clear scenario at the start of simulation about the systemic view of the ICU and hospital capacity. So I think our cases were quite clear as opposed to when they were, as they were related to the STMR, but there were still a lot of lingering questions as to how we would be backed up at a ministry and provincial level for this. We also had very limited information on what the consequences would be if we're not able to triage and what the alternatives would be to triage. So that made things a bit challenging for the simulation, because afterwards, when we were having our debriefing, a lot of the questions weren't about the logistics of triage, but rather the ethics of it. Attending physicians said that these were some of the hardest simulations they've ever done. And so we were doing this under incredible time pressure when people are quite stretched, and ourselves included. And so we found that we didn't have the necessary time to debrief and process them all the stress. So what we learned is that ideally you should be doing, as institutions, we should be doing this when we have some bandwidth, as opposed to when you have very limited bandwidth. Again, lessons learned, you can't assume participants pre-read. We had a lot of individuals and their division leaders who said, we are quite comfortable with the triage protocol, and I think we get it. But once you actually start doing the simulation, there's some very basic questions about triage. Like we had one clinician, step out of his role and say, I'm going to be calling a colleague at Harvard to discuss the mortality risk for this individual, right? So these are very basic, simple things that once we start doing the simulation, we realize clinicians really don't understand the idea of what triage is and deprioritization is. The discussion has to be interprofessional because our care is interprofessional, and the social workers and the nurses often deal with the fallout of these decisions. So that's why it has to be interprofessional, just so that we can simulate exactly what we do in real life. And of course, it's very important to keep the technology as simple as possible. So this was quite intuitive technology using a Google Drive that we created. And because it's such a complex task, I think it's important that the tech not be too hard for clinicians to adapt to. And I'll pass it over to Andrea.
Great, thanks so much, Haroon. I think one of the great benefits of doing simulation is that bidirectional communication. And it's really by living this process out, even in a virtual way, watching a clinician complete an STMR, watching them navigate a complex and really challenging end-of-life conversation with a simulated family or patient scenario, watching their communication with their interprofessional colleagues, that it comes home, that incredible complexity, the complexity ethically for sure, the emotional and moral complexity, the team complexity and medical complexity, and the systemic complexity of this issue. And we learned a lot about the triage process, where we were struggling, where there were gaps in the system, as well as what was working well. And so I would encourage us to consider simulation not just about education, but actually about quality improvement, and a critical part to the policy and analysis and policy implementation process. So a couple of things that we learned and observed in these simulations with the emergency standard of care that was approved and disseminated by the Ontario Critical Care Centre at the time. And one of them is that hospitals really need to have access to these subspecialists, because people completing the STMR again and again said, I need to be able to phone a friend. I just don't know enough about prognosis in the oncologic population. I don't treat that population. I just don't know enough about trauma necessarily. So the idea that people at the bedside doing the STMRs, who might be the hospitalists or the people on the wards, need to have, in some ways, access to a 24-hour phone a friend to do these quick consultations with folk who can help them to ensure the accuracy and timeliness of their STMR decisions. Recognizing, as Dr. Harper also highlighted, is that when patients are deprioritized and they won't get access to critical care, or when they are discharged from critical care and placed in the medical ward for either medical treatment and or palliative care, that this puts pressure on these medical wards in terms of providing a higher standard of care, higher acuity of care than they might necessarily be accustomed to. So those units also require some education and logistical support, including support from a rapid assessment team, et cetera. And the idea that who holds the patient and the family after a patient's been told that they're deprioritized for critical care, either that they won't gain access to it, or that they are going to be not able to continue on in the ICU. And so we recognize that we need to really consider triage a process where you have concentric circles of support. So that patient and family needs support, but the RN at the bedside who will be the person the patient and family really process that conversation and that decision making with, that RN at the bedside needs support, as well as the allied health supporting that RN. So what it really highlighted for us was, yes, the clinician, the physician at the bedside having the conversation needs to be able to have scripting and tools and resources to have that difficult conversation in a high quality way. But then to recognize when they leave to go see the next patient and do the next triage scenario, that we need to support the RNs at the bedside. And then the other thing that really was highlighted is this piece that a few people have said, absolute transparency is required around when an emergency standard of care gets activated. Is it at the provincial level? Is it at the regional level? What level of triage are we at? Are we at level 1, 2, 3? How do we downregulate from that peak of triage into an abating scenario? And that there's standardization, not just around documentation, but standardization related to the extent possible, how folk are trained, how data is collected, and how the consistency and quality of this process is monitored. And that could really be supported through regional coordination. The other thing that was highlighted is some opportunities for improvement of the STMR itself and the documentation process. So we really recognize that our current processes for having GOC as goals of care conversations or documentation of who our power of attorneys or our associate decision makers is not necessarily sufficient, especially when patients are coming into the hospital rapidly and we're having to admit them rapidly, that information may not be as readily accessible as we need. So it really pointed out a systemic gap, because ideally we'd be having these triage conversations, springboarding off a clear goals of care conversation and documentation about the patient's wishes and values so that we can really align their care planning with those. And we recognize that was a big gap. As Haroon said, especially for people learning it the first time, especially for people who are cognitively, emotionally overwhelmed, the STMR looks pretty simple because it's just about a bunch of check boxes in a table format on a form, but it does take time to learn. People do get faster over time, but there has to be some accommodation and recognition that when you're first learning it doesn't just take 5 minutes like it does when you've done it maybe for 5 or 6 days in a row, but that in the combination with the patient and family conversation can take up to 45 minutes. So how do we build a system where we might need 45 minutes per SDMR? What does that look like? How do we draw in learners? How do we draw in allied health? How do we draw in sort of the team around those conversations? We also talked about and recognized that the STMRs should be done on our highest risk patients first, prior to them needing it. Again, if it takes 45 minutes, you can't be doing this in a crisis. And then waiting for patients who are less at risk of clinical deterioration and requiring ICU care, doing those STMR conversations and processes later on. The importance of having the ICU clinician there on call to support. And also, to the extent possible, to use automation like calculators, like EMR monitors. Building this into the EMR record would also really help to make this more efficient and more accurate. And then we learned a lot about prepping for the process of triage. So again, the recognition, the MacDrop folder was really helpful to be able to have a central repository for folk across Ontario who were planning and implementing education about triage, that we all had a common repository of tools and forms and resources and scripts that could then be disseminated and adapted to local context, but that needs to be available across the whole system. And ideally, it would all be connected to a publicly accessible ethics framework that hopefully is deliberated by the public, where there's public engagement in informing that ethics framework. And ideally, in the next pandemic, we would have that as the ground that really creates the possibility of these clinical tools anchored in a common ethics framework with public engagement. And then it's the tools that kind of put that into practice in an embodied way. We also talked about the importance of having multiple stakeholders to provide input and to endorse these triage clinical tools like CMPA and HEROC and CPSO and our regional healthcare leadership as well. So important to coordinate and share lessons learned and not duplicate efforts, but to the extent possible, create standardization in our education and capacity building efforts. So ideally, we might have in future a series of regional triage committees that are all connected centrally so that we share resources, lessons learned, and we again enhance that standardization. So whether you're being triaged in Norfolk or in downtown Toronto or in Ottawa, there's this hope that we can have the same kind of standard of care offered to all Ontarians. That could be facilitated by having standardized data collection where we can actually track, as Dr. Harper attempted to do in doing some overview sort of surveys of our ICU patients during the third wave to see what is the opportunity here for actually creating capacity. What are the outcomes? What are the impacts at the population level on triaging or deciding not to invoke triage? And then again and again throughout this entire process, and we've said it multiple times today, we have to recognize that this is an incredibly distressing and challenging situation, not just for the physicians and healthcare teams at the bedside engaging in these decisions, but for patients and families who are processing the systemic overwhelm and the decisions being made, as well as for healthcare administrators and decision makers at every level of the health system. So the opportunity to have staff and a space available to articulate and process the stress, to have people feel grounded, to manage overload, and to also recognize that it is standardization that can help to mitigate bias, especially when there are processes in place to address quality improvement opportunities and to engage in two-way feedback on how triage is going from multiple stakeholders. So those are sort of our lessons learned from the experience of triage that inform the overall triage preparation recommendations for the future. Certainly some limitations in this. We did not get official feedback from clinicians who participated in our simulations. And so that would be really important in terms of perhaps building this into a study. But certainly we got really positive informal feedback from conversations and communication we had afterward. So that's sort of our whirlwind of triage preparation, the pros and cons of simulation, and what we learn from simulation that I think can inform policy, procedure, and process implementation for future waves or future pandemics. So we'll stop there. Happy to take your questions and looking forward to hearing your reflections. If you were involved in triage preparation at your hospitals, would love to hear about your education strategies, what worked, what didn't. And what are the lessons learned from this process that we could take into preparing for future emergencies? So, or that could inform our pedagogical efforts, even outside of the context of triage. So thanks so much, everybody.
Excellent. Thank you so much, everyone. So it's now time to turn to our discussion period. And for those of you watching on YouTube, you're able to type your question just into the YouTube chat. And if you'd like to send a question anonymously, you can send it to jcb.ea@utoronto.ca. And got a couple questions we've received from emails. Just open them up and get started on the discussion period. Okay, so our first question is about the, I guess, history of the triage document, or maybe the emergency standard of care document. And Andrea, I think you answered a bit of this, but I'll ask it again because we did get it a couple times. So they are asking who developed the triage policy that you were working with. So I think they mean the emergency standard of care document. And did anybody have any input? Who approved the document? And maybe I'll add, based on your last comments, I'll add, was it public? So you spoke about transparency, so you can tell us a bit more about that process.
Yeah, I can perhaps take that question. So we use triage as kind of an umbrella term it was officially called the Emergency Standard of Care for the allocation of critical care resources in the context of a COVID pandemic surge. And so understandably, that title needed to get shortened. And so we use sort of triage, since that's the conventional way that we think of hard decisions around who gets access to care and in what order. So this emergency standard of care, which was the sort of shortened version of the official document, was informed by multiple stakeholders. It was informed by bioethicists across Ontario, who provided a very thorough analysis of sort of the ethical dimensions of engaging in triage processes. And then that sort of draft framework was taken up by the Ontario COVID Critical Care Command Center, who were really charged with imagining the implementation of putting this ethics framework into practice at the bedside. And obviously that Critical Care Command Center was populated by folk who are critical care clinicians and people who ran the Orange system and who really had that systemic line of sight to critical care capacity across the province. And there were other stakeholders also involved. So when we talk about the triage protocol, the triage process, or the emergency standard of care, we're really referencing this province-wide protocol that was endorsed by the Ontario COVID Critical Care Command Center. And then from that original protocol, all of these resources were devised and adapted, including scripts and resources and FAQs and slide presentations and educational resources as well. Does that help, Angel? And your question about, was it public? It was certainly disseminated very widely across Ontario to healthcare organizations. So all hospital organizations in the province, all hospital CEOs in the province got access to this resource, the MacDrop folder, and to the protocol itself. So it was intended to be a document that is about clinical judgment and clinical care. So it was disseminated widely within the clinical community. Ultimately, it wasn't publicly disseminated, but there were a lot of public media reports and opinion articles that really did outline the overview of both the principles and the process for a public audience.
Thank you so much, Andrea. And I'll give other speakers an opportunity to add anything if you'd like before we go to the next question.
Yeah, one thing I'll just sort of add is that you know, the triage process in terms of the educational piece was like, you know, as Andrea said, it's an umbrella term, and there were parts of the protocol, for instance, that relate more to process related issues that would be sort of, you know, organizational or institutional specific. And then there's sort of triage criteria itself. And both of those evolved in tandem, and, you know, the triage criteria themselves influenced the policy to some extent, but in a lot of ways it was kind of like, we sort of had a triage process. How are we going to implement this? And then there was the actual tools and calculations and the STMR and who gets prioritized, that to some extent you could almost like black box while you're working on the other piece. And for an educational perspective, you know, like the calculations themselves are one thing, but what really, I think, took a lot of the educational focus was sort of that implementation piece, as opposed to like who gets prioritized. The real struggle was about how do you do it and how do you actually support the clinicians and the patients and the families, and that sort of went outside of the criteria themselves.
Yeah. So our next question is about the alternatives to triage. So I know in one of the slides you've mentioned that was one of the considerations in the setup for the simulations, and I'm wondering if you received any feedback from the clinicians involved in those simulations in terms of, you know, what they imagined those alternatives to be, or if your group has had discussions about those alternatives or how to frame the simulations when you've got maybe multiple ways of responding to a pandemic.
Yeah.
Maybe.
So Go ahead,
Go
Andrea.
ahead.
I think when we talk about, we didn't get too much in the way of feedback for alternatives from clinicians when we did the simulation. I mean, a lot of clinicians found it very hard to make that shift from being the patient's advocate to now focusing on what's best at a systems level. And so we had a lot of them questioning whether this was truly best for patients, and they did that during the simulation as well. And so, in terms of suggestions for alternatives, it's very hard for, I think, anyone who is actually within that simulation to imagine what alternatives would look like. Andrea, it'd be good to hear what you think.
Yeah, and I think it's really helpful because in the situation of an overwhelming critical care surge, like moral distress isn't optional. Moral distress will happen because there aren't enough resources to give appropriate and safe care to everyone. Even transferring patients is an incredible hardship and very dangerous for patients, and a hardship for families who are separated from their loved ones. So I think one of the ways, if we're promoting an emergency standard of care or a triage process, you know, as the most ethical of a range of bad options, where moral distress is not optional, but intrinsic in all options, then we probably should lay out the options so that we can actually support people, not to feel better, but sometimes in ethics, we choose the least worst option. And it's my belief, it's my contention that triage is the least worst option among other options. So some alternatives that I think we should transparently discuss when we're talking about triage and educating people about triage are things like randomization. Do we just randomize, like literally on the basis of a flip of a coin, who gets access to critical care and who doesn't? Should we always transfer out and sort of do this really aggressive load leveling, as we call it? Well, there are downsides to that in terms of hardships to patients, dangers, et cetera, like I was just saying. We have an alternative of just surging and surging and surging and surging until you have these ratios that are like, you know, 7 patients to a single critical care nurse or 10 patients to a critical care nurse, which we know also has a downside, as Dr. Harper was saying, in terms of safety, in terms of critical incidents, in terms of quality of care. And what we're seeing now, longitudinal impact on our workforce, where people are leaving healthcare in part because of the systemic overwhelm that they've experienced as clinicians. So taking the long view of immediate impacts as well as longitudinal impacts, and I think we have more information now about what the longitudinal impacts have been of surging and some of these alternatives. To lay out those alternatives might help people to feel at least a little bit better, maybe, about triage as an option, but it might also help the team to deliberate about where might we want to activate some of these options as an alternative to triage, or where might we need to pivot in order to activate triage as the least worst option. So those are some of the reflections I've had since around alternatives and the importance in actually articulating them and their pros and cons.
Thank you so much. So I know we have a couple minutes left, so we'll try to squeeze in 1, maybe 2 more questions. This next one's a clinical question, so I don't know if it's a long one or a short one. Dr. Okema and Ruth Ozema asked what your take is on an integrative medicine approach to emergency care. So maybe I'll put those to the clinicians on the Zoom.
I need a little bit more clarification as to what exactly they mean. Do they mean like the interdisciplinary care together? I'm just struggling a little bit with the specifics of that question.
So what I can ask maybe our viewers who pose that question, if you can put a bit more information in the YouTube chat, and we can maybe connect you, because we're coming up to 5 o'clock, we can connect you afterwards to maybe continue a bit of that discussion if that's okay with you, Haroon. We'll do that. Okay. All right, so make sure to do that. And then our next question is, so about one of the slides there in the presentation, it included an image of a chart that showed different levels of triage and what would follow. And they say this was also presented by the American College of Chest Physicians. Is this a chart that was modified for the Ontario context? I don't know what slide number that's on.
Is that Simon's?
Yeah, I don't know if it was. It may have been. I mean, one of the really strange and frustrating things about the pandemic for those of us who were like thinking about triage was that it seemed to be a very haphazard approach around the world in terms of what people were doing. Like, there's, emerging literature and reviews on sort of the approaches different places took. And in a crisis, everyone was sort of borrowing and stealing from everyone else. So it's quite possible that slide was used or adapted elsewhere because everyone was looking to everyone else to figure out what to do. And I think that's a problem because when you're thinking about something like triage, you want it to be locally responsive, but really to be fair, it needs to be consistently applied across an area. So, it should be consistent around Ontario. I don't know whether or not triage in the States and Canada should be the same, but I wouldn't be surprised if they were looking at our materials because we were certainly looking at theirs. And there are very different approaches taken in different places.
Thank you so much. So unfortunately, I think we're at time and we'll wrap up our session today. So before I draw the session to close, I just have a couple of announcements to make. Our next seminar will take place on March 9th, and Owen Connolly and Roz Abdul will be discussing involvement of the Consent and Capacity Board in challenging ethical impasses around substitute decision-making. To sign up to receive our weekly seminar reminder emails, please send an email to jcb.info@utoronto.ca. For the CSB students who are enrolled in the CSB Student Seminar course, please remember to keep track of your attendance. And last, certainly not least, Haroon, Andrea, Will, and Simon, on behalf of all of us here today, thank you very much for your presentation. Well done.
Thank you.
Thank you.